This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us for our HealthyU webinar series. Today's topic is a healthy mind and body. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentations conclude. Your questions will remain anonymous. We have three presenters today. They include Dr. Chan, Dr. Orr, and Dr. Donahue. We're going to start off with Dr. Chan. He's a breast imaging radiologist at Mather Hospital and attended medical school at SUNY Upstate Medical University. He completed his transitional year at Mather Hospital and his radiology residency at Tufts Medical Center. He completed his fellowship, his breast imaging fellowship at Northwestern Medical Center, and he has also presented at the Radiological Society of North America and the American Society of Neuroradiology. Dr. Chan, let me get your presentation up and then we're good to go.
All right. Hi, everyone. Thank you so much for joining in on this talk. Thank you so much for introducing me. I am a breast imaging radiologist currently at the Fortunato Breast Health Center at Mather Hospital. And today I am planning to talk a little bit about breast cancer and also what you can do about breast cancer. And next slide. So to begin with, what exactly is a screening exam? So there are many different types of screening examinations, including breast mammograms, but other ones that you may have heard about include things like pap smears or colonoscopies. And overall, the goal of a screening exam is to catch a disease process before you notice any symptoms, or to try to catch it early so that we can kind of nip things in the bud. Next slide. So generally speaking, mammograms are done in a fairly similar way across multiple different institutions. There may be slight differences, but overall, what you can expect is when you come to the breast center, you'll fill out a questionnaire that will where you will list things like your family health history, or if you had prior breast procedures. And in general, it just kind of helps the breast imaging radiologist, the person who interprets your mammogram, get a sense for what sort of things that may put you at risk, or what sort of procedures that you've done before, so that they can properly interpret your image. And the mammogram is performed in such a way that essentially we use two plates to compress the breast, and then take an image, and then release the compression, and then do the compression again, but from a slightly different viewpoint, from a different slightly angle. That essentially helps us get two different views of the breast. Next slide. So, I hear a lot of people, a lot of females, they tell me they really dread their screening examination, and that's not what a mammogram exam should be like. It's not meant to be a painful experience, a torturous experience like going through a really, really long TSA line. At least at the Fortunato Health Center, our staff members are really, really gentle. They're kind, and they'll help you guide you through the screening mammogram exam. Next slide. So, why screen for breast cancer? So breast cancer, believe it or not, is actually really, really common. Research have shown that 1 in 8 women in the U.S. will develop breast cancer in her lifetime. So everyone here might actually know someone who has breast cancer. So it's a very common disease, and that's why the screening mammogram is very important. Next slide. So this is a very busy chart, and essentially, so I'll go over this chart. So this chart essentially shows the benefits of doing a screening mammogram, and this chart comes from this study that I listed on the bottom here, called the Swedish 2-county trial: Impact of Mammographic Screening on Breast Cancer Mortality During 3 Decades. So the blue line in this chart essentially are the people who did not get screening mammograms, and the red line are the people who got screening mammograms. And on the y-axis on the left is the mortality rate that is attributed to breast cancer. And as you can see here, the blue line is significantly higher than the red line. So people who did not get screening mammograms had significantly higher rates of death related to breast cancer compared to the people who got screening mammograms. And another thing to notice here is that this difference between the two lines, it gets wider and wider as you get further from the initial time point. So you actually derive more benefit from screening mammograms as you get more of them. So the two takeaways from this is that A, screening mammograms help save lives by reducing breast cancer deaths, and B, you get additional benefits from screening mammograms as you get more of them. Next slide. So, there's a lot of different organizations out there that have different takes on when you should get your screening mammogram and how often you should do it. Different organizations have different guidelines, societies like National Comprehensive Cancer Network, U.S. Preventive Task Force, American Cancer Society. Everyone has a slightly different take, but everyone agrees that you should get screening mammograms. And I'll share with you what the American College of Radiology, my professional society, recommends. Next slide. So the ACR recommends that for the average risk woman, they should begin getting screening mammograms beginning at age 40. And as long as you're in good health, you would continue getting get screening mammograms. Next slide. And the 4 images on the bottom here kind of shows you what a breast mammogram may look like in 4 different women. And they have different densities in here. From the left side being what we call fatty, and on the right side being extremely dense. And the importance of this is that so there's several different reasons why breast density is important. Breast density is an independent risk factor for breast cancer. So people who have denser breasts have increased risk of breast cancer compared to those who have less dense breasts. And another thing that's important is that breast density plays a role in how easy it is to detect breast cancer. So the analogy that I like to give is that the females who have fatty breasts, their breasts are kind of like a crystal clear pond, and people who have extremely dense breasts have the equivalent of a somewhat murky pond. And in the crystal clear pond, you can see the fish very, very easily. And in the slightly murky pond, in the extremely dense breast, it's a little bit more difficult to see the fish. And the fish in this analogy is the cancer. So it's just a little bit tougher to see breast cancer in extremely dense breasts compared to fatty breasts. And that's not to say that the mammogram is no longer useful. It's just a little bit more difficult to find breast cancer. Next slide. So there's different ways that the breast imaging radiologist can kind of try to see through the murky water. So on the left-hand side of the screen, you can see this first image is what we call a 2D mammogram. And then the 4 additional images to the right of that image, labeled image 36, 40, 43, and 46, are what we call tomosynthesis mammograms. And what tomosynthesis mammograms does is it essentially slices the breast into multiple different slices. It partitions the breast. So it's almost like peeling back an onion, so that every layer you take back reveals slightly different information compared to the layer prior to that. And in the image labeled 43 here, you can see that there's a breast cancer hidden in there that is magnified in the bottom right. And this is much more easily seen on this image compared to the most left image, where it's kind of hidden away. So that is the advantage of performing a 2D versus a 3D, what we call 3D tomosynthesis mammogram. Essentially, 3D tomosynthesis images lets us see past the density to a certain extent. Next slide. And another way that the breast imaging radiologist can see through dense breasts is by using ultrasound. So breast ultrasound uses a slightly different way of acquiring images. it uses, as the name suggests, sound waves to acquire images compared to mammograms, which uses X-rays. So obviously, one of the benefits is that the breast ultrasound doesn't have any radiation associated with it, and it's just another benefit is that the breast ultrasound gives the radiologist a different view of the same breast, so that you can have another chance to find breast cancer. Next slide. And in this image, we see this is what a breast ultrasound may look like, and that's a way that we can use to kind of see through the that murky water that I mentioned earlier. Now, so on the bottom here, I mentioned I showed some statistics from research articles where they found that in mammograms, if you do approximately 1,000 mammograms, you can find approximately 6 breast cancers. And by doing mammograms with tomosynthesis, the 3D images that I mentioned earlier, they can find an additional 2 breast cancers on top of the 6 breast cancers that you would have found if you had just used regular mammograms. But additionally, they found that if you add screening ultrasounds on top of the mammogram, either 2D mammogram or the mammogram with tomosynthesis, they can find another 3.7 cancers. So obviously you can see here that the breast ultrasound can help you find additional cancers. And the downside to using the breast ultrasound is that it's a fairly time-intensive task. We need a ultrasound technologist who is able to scan each breast, and they take their time scanning each breast. And to a certain extent, the efficiency or usefulness of the ultrasound exam itself, it depends on the ultrasound technologist and how good they are in recognizing when something's abnormal and bringing it to the attention of the breast radiologist, who can then evaluate it to see whether or not it could potentially be cancer. Next slide. And then finally, we also have the MRI. So in the MRI, you see this kind of like donut-shaped machine where the patient kind of slides into the donut, the hole of the donut, and the MRI uses magnetic fields to generate images for radiologists. So the MRI is very useful if if a patient has high risk for breast cancer, and there's multiple different things that can contribute to someone having high risk for breast cancer. Things like having family history of breast cancer. If your mother, if your daughter has breast cancer, that could be a sign that you may be at high risk for breast cancer. But that's something that you can talk to your primary care doctor about to see whether or not a supplemental MRI could be useful for you, because you may be a high-risk patient. And so that concludes my talk. Thank you so much for your time. Hopefully, I've showed you a little bit about breast cancer screening and convinced you to get breast cancer screening mammograms. Thank you.
Thank you so much, Dr. Chan. Next up, we're going to be with Dr. Orr. Dr. Orr graduated from Technion Institute of Technology Medical School in Israel. She would later move to the United States in 2008 and completed her residency in Lenox Hill Hospital in gynecology. She also completed her fellowship in minimally invasive gynecology surgery, and she received her certification in the North American Menopause Society, and now she is an NAMS certified provider. Dr. Orr, the floor is yours.
Good afternoon. So I am going to touch menopause and breast cancer. It's a very touchy subject because a lot of women that go through menopause are symptomatic, but the medications that we can use are more limited because of the breast cancer. So I'm going to touch a little bit of that. Next slide. So the goal is basically to review the menopausal symptoms briefly, and then to review both lifestyle changes and medical management options for the more common symptoms of menopause. Next slide. So if we're looking at menopausal symptoms, the first thing that is important to understand is that over each year, about 200,000 women are diagnosed with breast cancer. And sometimes the treatment itself will induce menopause, because they get chemotherapy that will induce menopause, because the woman is placed on tamoxifen, which is a medication for breast cancer that can induce menopause, other medications like aromatase inhibitors, or even recommendation for surgeries to remove the ovaries, which will cause surgical menopause. And a lot of times, because of the initiation of medications, the symptoms will occur very quickly, very abruptly, and they would be very, very severe. The symptoms that are most, so you see there's a lot of symptoms, hot flashes, night sweats. A lot of times there is sleep disturbances, vaginal symptoms like dryness, pain, some urinary symptoms, sexual dysfunction, depression and anxiety, and hair loss. So, you know, the most common things that we see are hot flashes and the vaginal symptoms. Hot flashes and night sweats I put under the same criteria, even though they're a little bit different. You know, as many as 80% of women at some point just before or during menopause will have hot flashes, and up to 15% of them will have severe hot flashes, meaning it will really interfere with their day-to-day life. And over 80% of women have vaginal symptoms, be it vaginal dryness, be it burning or irritation, or urinary tract infections, or even urgency and pain with sex, and so on. So, you know, hormonal options that are available in general for the general population are less readily available for menopausal women with a history of breast cancer, because a lot of those cancers are receptor positive, meaning they have estrogen and progesterone receptors. So if I will give them any medications like this, it can cause the cancer to grow. And so we don't want that, of course. You know, a lot of times there are herbal medications that are out there on the market. Honestly, we did a ton of studies on these herbal medications, and at the end of the day, they're exactly like taking a sugar pill. We don't see any use in using these. And what I always tell my patients is also, we've studied all of these. If this would have worked, we would have made it into a medication already. Next slide. So there are non-medical approaches to hot flashes. Some of them have been studied more thoroughly. Some of them have been studied less thoroughly. Some of them are very distinct. Some of them are kind of maybe yes, maybe no type of things. Next slide. So the first thing is, of course, to avoid hot flash triggers. Everyone is a little bit different. Every woman has her own triggers. It's important that a woman identifies her triggers. Some people will be triggered by alcohol. I recently had a patient who told me that when she took off caffeine from her morning routine, her hot flashes were gone. For example, certain foods, a lot of times it's spicy foods, and smoking are hot flash triggers, for example. Next slide. It's important to keep the core body temperature cool. What does it mean? It means just stay cool in whatever way you can. A lot of times in the winter, I'll say dress in layers so that if you get hot, you can take it off and then put it back on once the hot flash goes away. Use natural fibers such as you know, silk or rayon, cotton, or a wicking fabric like they use in exercise, the thing that kind of gets the sweat away. Use cotton sheets and use cotton underwear also, because a lot of women complain also on excessive sweating in the groin area. Always keep a bottle of water available, be it next to your desk, next to your bed, wherever you are, have a bottle of water. Keep a small fan, either at the bedside, at the desk, even a tiny hand fan in your bag can be helpful. A lot of times women find that placing a frozen cold pack under their pillow, and then when they wake up because of a hot flash, they can turn over the pillow and then that side would be cool, and that helps. And of course, it's always helpful to invest in air conditioner or a ceiling fan that are effective in order to help with the symptoms. Next slide. You know, maintaining normal body weight. What we see is, and that's a little bit, it's one of those things that we're not absolutely sure about. We do know that women who are overweight or obese have more severe hot flashes, more frequent hot flashes, and more women who are obese have symptoms of menopause. Studies have gone to both sides, but we think that if we maintain normal body weight, the hot flash frequency and the hot flash severity can decrease, so that can be helpful. Next slide. And then refrain from smoking, either active smoking or even being around people who are smokers. That can, it actually increases the risk for, specifically the risk for hot flashes. Next slide. Exercising regularly is another one of those things that the question is, does it or doesn't it help? What we think is that low impact exercises can assist with fewer hot flashes, shorter duration of hot flashes. But if you start doing high impact exercises, of course, that's not going to help. That's just going to make them come worse. So if you do low impact exercise, that can help with hot flashes. Next slide. And then there's relaxation techniques such as yoga, such as meditation. Those have been studies, and again, there's no definitive saying whether it's helpful or not. But what we think is that when you do these techniques, you are less anxious, and if you're less anxious, we do see that there are less frequent and less severe hot flashes. So we would always encourage women to do that, and plus it helps in life in general. Next slide. So if we talk about medical management of hot flashes, so there are several medications that are not hormonal medications that we can use for hot flashes in women with history of breast cancer. The problem with hormonal treatments with breast cancer is, like I said before, a lot of these tumors are sensitive to hormones and they will grow if they are given hormones. Basically, it's their food. And so we have to find different medications in order to help women with a history of breast cancer. So clonidine, for example, is a medication for hypertension, actually. It's used for high blood pressure. It's given twice a day. It's actually not the medication of choice in general in the United States because it's a little bit less effective and it has more side effects like dry mouth and headaches, and it can't be stopped abruptly because it can affect the blood pressure. It is a medication it's actually the only approved medication in the United Kingdom for hot flashes. SSRIs and SNRIs are basically antidepressants like paroxetine, which is it's called selective serotonin reuptake inhibitors or selective norepinephrine and serotonin reuptake inhibitors. Those are very common antidepressant medications. Paroxetine is the only medication in the United States in terms of SSRIs that is approved for menopausal symptoms, but we do use others because they are helpful. They are given a lot of times in lower doses than what we would use to give for depression. Sometimes insurances won't approve them, so we'll give the depression doses, but it's really insignificant. Paroxetine is my go-to medication. However, when patients are on tamoxifen, and a lot of cancer survivors are on tamoxifen, I would go to either venlafaxine or sertraline. Because what happens is with paroxetine, for example, it interferes with the way that tamoxifen works. They both use the same pathway in the liver. So we would want to make sure that we're also not interfering with the medication that is used for the cancer treatment. And then there's other medications like gabapentin, which is used mostly for hot flashes that are at nighttime. The main side effect that has is a little bit of tremors, but when women are very, very symptomatic, especially at nighttime, gabapentin can be very helpful. And we can use oxybutynin. That's actually an overactive bladder medication. So if you go to the bathroom a lot and you have to pee a lot, we use this as a medication. And recent studies have shown that this at a very low dose actually reduces hot flashes significantly. We have to be careful a little bit with patients with diabetes, and it can cause dry mouth, but overall it's a good medication. Next slide. So for the vaginal symptoms, there are, again, non-medical and medical management options, and the medical management options are divided into non-hormonal and hormonal management options. I actually gave another talk like this about 2 weeks ago regarding vaginal symptoms in general in menopause. So the non-medical management options for vaginal symptoms are regular sexual activity and self or partner stimulation, as well as vaginal stretching and dilators. The main problem with vaginal symptoms is that a lot comes with narrowing of the vagina and narrowing of the entry to the vagina, what we call the introitus. And so we want to make sure that the vagina and the entry to it are patent. And the way to do it is to use dilators, stimulation, and sexual activity. And of course, in patients that the condition is very severe, a lot of times pelvic floor physical therapy will be very helpful. Next slide. Non-hormonal management options of vaginal symptoms are mostly lubricants for intercourse and vaginal moisturizers. Next slide, I'll expand a little bit on that. So vaginal lubricants are used specifically during intercourse. There are several types of vaginal lubricants. There's water-based, there's silicone-based, oil-based, and there's a lot of times you can do the petroleum jelly. I personally, as a physician, prefer the water or the silicone-based. My favorites are silicone. They're much nicer. They're good on the vagina. They're good on the vaginal pH. They behave well on the vaginal pH. The problem with oil-based and petroleum jelly is that they both increase the risk for bacterial vaginosis, which is a bacterial infection of the vagina, and they increase also the risk for candida infection in the vagina. So we're trying to make a woman feel better, not worse. And so I would always recommend either a water-based or a silicone-based. If part of your sexual routine is using toys, then it should be water-based. Otherwise, silicone is just fine. Moisturizers are the same idea as moisturizers for the face. You get up in the morning, you put a moisturizer on the face. So the vaginal moisturizers are not every day, but they are 3 times a week, not consecutive days. They are placed in the vagina, and I always tell my patients to put a little bit also on their finger and rub it in the entry to the vagina and a little bit on the labia, what we call the introitus, in order to help with the both stretching and moisture in the area. It works really well for a lot of women, for about 70–80% of women, but it is a long-term type of management. Just like you would continue putting moisturizers throughout your life on the face, you should continue doing moisturizers on the vagina throughout your life. It takes time to see improvement. It takes up to 12 weeks. So, a lot of people come to me and I tell them this and then they forget because you want immediate results, of course. And you have to remember that it can take up to 12 weeks to see improvements. You have to be patient with these types of medications. Next. And then medical management of vaginal symptoms are a little bit different than any other medications for breast cancer patients. That is because topical estrogen is actually okay in breast cancer survivors. What happens is that the topical estrogen is in such low doses and it's so local that it hardly gets absorbed into the system. And so we see that there's no real difference in the estrogen level between a woman who is menopausal and uses estrogen in the vagina or doesn't use estrogen in the vagina. That being said, of course, we want to be careful because we don't want to increase the risk for anyone. And so usually if I have patients who have failed vaginal moisturizers, have failed other things, I will talk to their oncologist first and will make a shared decision on whether this is appropriate for my patient. There's another option, it's called DHEA, it's called, the brand name is Intrarosa. It's actually a precursor of testosterone that when we put it in the vagina, it turns into estrogens and progesterone and testosterone. And so again, this is the type of medication that I will talk to the oncologist before giving to my patient. But honestly, it's very, very safe, even in breast cancer survivors with hormone positive cancer. And then there's another medication that is an oral medication. It's used a lot of times for pain with intercourse. It's called Ospina, or the generic is Ospemifene. That is less used. It's not used actually in breast cancer patients because of the concern of how it will affect breast cancer. But I will say that there have been studies up to 52 weeks with this type of medication, and it probably actually decreases the risk for breast cancer. So there may be some more on the horizon in terms of medications for the vagina. Next slide. And that's it. Thank you very much for your attention.
Thank you so much, Dr. Orr, for your presentation. Last but not least, we have Dr. Donahue. Dr. Donahue went to the University of Maryland School of Medicine and completed her residency at Zucker Hillside Hospital. She was a clinical assistant professor of psychiatry at Stony Brook for 15 years until coming to Mather 7 years ago. Currently, as medical director of the Department of Psychiatry, she is dedicated to expanding mental health services in the community. Dr. Donahue has a special interest in advocating and educating families in the autism community. Dr. Donahue, let me get your PowerPoint up. All right, you're set.
Okay, thank you. So the two topics we had before were very much geared to women. In this presentation I'm going to give, really could be applied to men or women, but I think women tend to be particularly hard on themselves and not very forgiving. So when I was trying to think of basically how to start this, topic today, as we go Christmas, I go shopping and it's already 11 weeks to Christmas. And I realized back to the times during the pandemic that things were a lot different last year. I think our COVID rate was about 10%. People were canceling their holiday celebrations. And, this year things have been more positive, and I think people are looking to move on. But I think what people don't realize is they need to have some closure. And in order to move on, we have to kind of deal with what's gone in the past to move forward. Okay, next slide. All right, so to do this, we have to heal and we need to process this. For some people, they were so busy during the pandemic, working many hours, depending what type of work people did, or some people who were working from home. And then there were people who took on, new roles. There were many women who had jobs that used to take them outside the home, and now all of a sudden they had children that needed to be schooled inside the home. And this was very difficult for a lot of women, and during the pandemic I saw quite a few of them, and many of them felt that they weren't doing a good enough job. They felt that all these demands were pulling them and they had to make choices, and sometimes that also involved new routines for people, especially now that people couldn't go out, couldn't socialize, and then people were, taking on, sometimes we had grandparents in the house, or sometimes we had fathers that were staying home and doing this job. So there were a lot of new routines for people as well. But in order to move on, we have to kind of reflect on what happened to us. And part of this involves just a whole kind of grieving process. Next. Okay, you can go to the next slide. All right, so now people think of during COVID grieving. There were many people that lost people in their life, which was very difficult. But grieving isn't just about losing people. We're grieving what has been lost. The pandemic affected everybody on many levels. And for some people, it wasn't one specific thing. People who had lost loved ones or friends, that was like an obvious, okay, a grieving process. But there's a collective grief. We lost a sense of normalcy, the routines that we had. Now people who would like to go to the gym couldn't be going to the gym. People who were socializing, going out to restaurants couldn't. Kids that were playing, sports or different activities all of a sudden couldn't. And all the things that we basically took for granted as part of our normal day-to-day life. And then, of course, there was a delay in connections with people, people feeling, lonely, people not being able to reach out and contact other people. We certainly had some improvements with our technology and things like Zoom and Teams. People were able to connect that way, but still there was a very impersonal, sense there. And for some people, there was a fear, there was a big economic toll. While some people had their livelihoods disrupted, or their businesses, and they took a financial, hit, and, they found themselves in situations, some people going to, churches or kitchens to get some extra groceries, but it didn't, some people were unaffected by it, but for some people it really changed things. Yes, there were some people that got their unemployment and it helped keep them afloat, but it wasn't the same. And it was a lot of the not knowing where things were going. So in order to move on, we have to find some meaning and kind of hope to things, how they've changed. Okay, next slide. Okay, so many people are aware of the Kubler-Ross stages of grief, but this I'm kind of applying to the pandemic. We have to think of kind of where we were. And, initially when all this was going on, I remember it was the beginning of March of 2020 and all these rumors. And I think it was the 13th or 14th where life kind of halted. And before that, it was a sense of, this isn't going to affect us. This affects other people. We didn't realize how pervasive this would be within our lives. And then once it did happen, and there was a sense of anger. You're making me stay home. I can't can't do my activities, can't go to the gym, can't socialize, go out to dinner. And certainly people go through different stages of grieving in a different way, and they don't always go through it in the same order. Then as this kind of dragged on, many people were still working from home or not working at all. There's a bit of bargaining. You know, if I social distance for 2 weeks, then maybe things will be better. Maybe I'll be able to go out and see people. If I quarantine, get the PCR test, the COVID test, people were running all to these, you know, emergency health places to get, you know, COVID testing. And then eventually there was a degree of like, when will this end? A certain sadness to it. But then I think when people got to a little bit of an acceptance, and some people say, well, I never really accepted this. This isn't something I wanted, but nobody wanted this. But basically the reality of, you know, is this really happening? You know, we have to figure out how to move forward. And basically we had this, and I hate this term, this our new normal. You know, there's really nothing normal about walking around with masks on our face, but that became the big thing when I left, you know, to go out, to go to the store. It wasn't just my pocketbook, my wallet, my keys. It was, do I have a mask? People would, you know, look at you if you didn't have one on, or basically a lot of places you went to, you had to have one on. Next slide. Okay, so to deal with some of this, you know, some of this for people have moved on, you know, further ahead. I have some people, I saw a lot of patients who during COVID, I was doing Zoom sessions, and people were so kind of desperate for that kind of human contact that I found my sessions went on longer and longer because people just wanted somebody, you know, to talk to. And there was a lot of, because people couldn't socialize the same way, there was a lot of social distancing, and that made some of this harder for people who had losses, you know, meaning people or people who had other just losses in our lives. Now, the thing is, sometimes people also, they feel that they don't want to burden people. I had some patients, you know, reporting that, well, I wanted to talk to my friend, but they just lost their spouse and they felt like their problems weren't as big of a deal. But there really still is, you know, a loss, some pain there. The other thing is people also have to be able to ask for help, to open up to people. People sometimes don't want to let others know what they need. People are very proud and they sometimes don't, you know, want to ask for help. Next slide. Now, some people felt that, you know, they were feeling lonely. This is all a normal part of grief. Sometimes I found patients of mine were afraid to talk about these things because they felt something was wrong with them, or that somehow they needed to be on medication or something. And that's not true. There's some people that they just needed somebody to talk to and process this, which is why I'm bringing this up. You know, grief impacts people on everyday life. Like I said, if you lose a person or someone that was significant in your life, you know, you may have new routines, or all of a sudden people, I had women who all of a sudden needed to get jobs that hadn't had jobs before. But everyone experiences it differently. And, you know, people, they were talking about two different things: loneliness, which was the fear of being alone or separate. And then we had the social isolation of people not having their social contacts, people not being able to interact with others on a regular basis. I don't know if people had seen on the internet, there was these pictures of these children visiting their grandparents, and they had these big screens with these big plastic like shower curtains, and they had hands so they could put their arms around and hug their grandparents and or their loved ones. And there was this degree of wanting to be a part of things. And the more people were able to get creative like that, I think the better things were for them. They felt less isolated. Okay, next slide. And what I also told my patients, it's okay to feel the feeling. People sometimes are afraid to be feel anger, upsetment, sadness, and they often minimize, well, other people have it worse than I, so I shouldn't be feeling so sad. And when you set things up, this I shouldn't, that really kind of negates your feelings and doesn't validate you. But once the people talk about things, I think they realize they're not the only one. When I told people, oh, I have other patients like that, they were felt better. The other thing is, you know, sometimes if we, like I said, if you're feeling sad, stop there. Feel it, let yourself feel it. Sometimes people, they will say, well, I feel bad, or I don't want to have a pity party. And I tell people, you know, sometimes you have to have that pity party. You're the only one that shows up. You get to cope in the way you want, eat junk food, cry, laugh, whatever. But it's okay. You need to do this and then be able to move on. And that's why, you know, talking about this and kind of having the whole grieving process, because there are positive things that can come out of this. Okay, next slide. The other thing is people often feel better when they're helping other people. And when people feel maybe alone, they look to others once they kind of realize they need other people. And I had patients that were joining support groups. And then this was something, this whole COVID pandemic affected so many people. So many people lost loved ones or friends. And there were a lot of good support groups online, which, while some people found that difficult, they prefer to be in person. For some people, they liked it because there was a degree of anonymity there, that they were able to grieve and kind of have a little still privacy there. So they felt a little safer. And despite a pandemic or no pandemic, companionship is how we survive. This is how we get through things. And, you know, after people have losses in their lives, people who've been in like support groups or therapy, they find the fellowship of the other grievers remain. Sometimes they find these really strong bonds. And I have many patients who still to this day, even after the worst is over, they still reach out to each other because that's their support, and they realize that they have other people that understand exactly what they've been through. Next slide. During this, people also had a sense of they felt bad. People would ask them to things, and it's more so now that we're getting out and about and you know, kind of going back to a normal life. But they've said no to things, or, you know, in the middle of some type of event, it was too emotional for them and they had to leave. They also felt that they were declining things, and there was an expectation to do things, and everybody grieves differently, and there's no social faux pas when grieving. Like I say, basically, there's not, people may have their own expectations that they're supposed to act a certain way, but most people are very sympathetic to someone else if they have to leave or from an event or not attend something, because, you know, people have to walk in other people's shoes. And I think it's usually the person that is not doing things, they're the ones that feel bad. People tend to be very hard on themselves. And I tell people that, you know, we often have to put ourselves first. If doing something is just too painful for them, they shouldn't do it. If it's something that's taking kind of emotional energy out of them, they shouldn't do it. They have to put themselves first. You know, when we talk about kind of self-care, self-love, talking about something like being selfish seems to have a very negative connotation, but I think if we look at it more as self first, putting yourself first, putting out there what you need, what you don't need. You don't owe anybody any explanation. You may feel like it, but honestly, the people that are in your lives that care about you will understand. The people that don't understand in your lives, well, maybe those aren't really people that are close to you or in your inner circle. So you have to do what's best for you. Next slide. Okay, and like I had mentioned, it's finding a balance between too much, too little. Some people were not doing things as people are coming out of the pandemic. Some people were trying to make themselves, you know, isolated. They don't want to deal with things. And then there's some people that were trying to do too much to keep themselves busy and not think about things that were going on. And really, you have to process these things. You know, as an adult, I remember my mom saying, you know, once you become a parent, once you're an adult, you don't think, you just do. And I think a lot of that was going on during the pandemic. People weren't giving themselves a chance to, you know, just be. There was just this constant sense of going. And even though we were isolating, there was less to do. There were so many things that we were doing differently. Shopping, you know, just going out to stores, taking kids to do things or homework assignments. There was a lot going on there. We had to change the ways. So we all had to become a little bit inventive and creative. And with many of my patients, we started talking about just little things that can make their day better. Things, my screen just went, things that were going to allow them to focus on things other than what was going on. It's important that anything that does drain your energy, and this is something even now we should all do on a day-to-day basis, just say no. You take care of yourself. Don't overdo it, and you have to find some balance in your life. Next slide. So basically, how do we do this? How do we heal? Once we kind of go through this whole grieving process, I think the part of that I want to talk about is just how do we move on? We heal ourselves, but what to do? And I don't know if people seen that acronym, KISS, keep it simple, stupid. I don't like stupid, keep it simple, silly. We've got to move on there. So people need to let go of what they can't control and just do their part. I think we saw through COVID, there were a lot of things that we just expected us to be able to do. And all of a sudden we were telling no. And for people, I had quite a few people with getting married, had to cancel weddings, or some of them just made the best of it and said, you know what, we're going to do this. And if we have masks on, or we have to cut down the size of, their event, they did that. But those people, once they decided to kind of just say, this is what it is and let go, they tended to, I think, adapt differently. They'll have stories to tell their, family down the line of, how differently they did things. People having these celebrations, these birthday drive-bys, grandparents hugging them through these plastic curtains, different things with kids being home. All of a sudden they had more time to spend with them. Family dinners. I have a family of 6 kids and my husband, and it was the first time we had so many family dinners together. And these are things that we have to look in a positive sense, that had COVID not happened, we would have never gotten that opportunity to do so. People also, some people started doing more exercise at home, couldn't get to gyms, so there was a big surge of people with exercise equipment and people doing things, more yoga, meditation, different breathing exercises to kind of help them cope. I saw a quote, it said, stock up on compassion. And if you think about it, we tend to be very, people can be compassionate towards others, but I think we also need to be kind of forgiving of ourselves and give ourselves a break sometimes. And these are things, when we do things for ourselves, this is what's going to allow us to kind of heal and move forward, so we can put this whole, when I say put the pandemic behind us, but just take that and kind of use it as a springboard to kind of get us ahead. And also, it was a time people became very creative during this time of COVID, and people went back to basics and board games and reading. People started doing all these home improvements. Many people got pets during the pandemic as well to keep them occupied. So there was a lot that we did to move forward and as part of the healing process. And I think it's very important for people. Even now, I have some people who are kind of I had some patients who never left the house to begin with, maybe once a month for their appointment, because maybe they had some anxiety issues. And so when COVID happened, it wasn't a big change for them. I had people who just went on regular life, taking care of things. And then I had people 18 months later who, once they started going out and doing more, they realized they had put their whole life on hold. So people, while they handle it different, the important thing is we kind of grieve it and move forward. Some people have different coping skills. Some people have different inner strengths, and they can move faster than others, but there's no right or wrong. The important thing is that we kind of face this and then move ahead, and that's what's going to kind of propel us to rebuild ourselves. Next slide. So, like I said, even if you were lucky enough not to lose someone to COVID, we all need to grieve. We all lost something. And now it's really, that's what we can do to kind of move forward. Next slide. I included here just some list of resources because I think during this time, there were many people that wanted to reach out for help. Some people finally had the time to do so. And due to the internet, there's some great resources. Even if you go to the next slide, there's crisis hotlines, but there was also, if you can do the next slide, there was different response. One thing that a lot of my patients took advantage of was a crisis text line, because that they were able to remain, anonymous. There was no face to them, so they weren't on any type of, Zoom chats or other support groups. So I included them just because many people had asked for some resources. And that's it. Thank you.
Awesome. Thank you, guys. Thank you all to the 3 presenters for your very informative presentations. If anyone has any questions, you can enter them in the Q&A feature at the bottom of the screen. All questions are anonymous to protect your privacy. We'll give it a little little bit here to see if anybody has any questions. All right. Well, thank you, and thanks to everyone for joining us today. If you have any additional questions, please email them to matherhospital@northwell.edu. Once you exit the webinar, you will see a link to complete a brief survey. If you could please complete the survey, your feedback is extremely important to us and help us plan our future programs. Thank you all for joining today's webinar. If you'd like to view other HealthyU webinars we have presented, you can find them at www.matherhospital.org/healthyu. Thank you.